time for questions to the Minister of Health. Questions 7 and 11 have been withdrawn, and I call Keith Buchanan.
Question 1, please.
Sir.
I thank Mr Buchanan for his question. You may be aware I've campaigned on mental health since I was first elected in 21 and celebrate some of the achievements, the mental health champion, the mental health strategy, the enhanced awareness, but when it comes to waiting lists, not so good. I am keenly aware all trusts are experiencing significant pressures as a consequence of increased demands upon mental health services. And that includes the increased numbers of new referrals, but not just numbers, also the increased complexity and the acuity of people who are presenting. Of course, there are also the well-publicised financial constraints. There are also significant workforce pressures as a result of increased vacancy levels. So trusts are reporting they're dealing with more complex presentations, and as a result, people are needing longer treatments before discharge, and that itself is impacting on throughput and on waiting times. There have been some improvements in waiting times in relation to the Children's and Adolescents Mental Health Service, CAMS. However, the overall picture is one where, although activity levels are increasing, the levels of demand are increasing more quickly than that. In addition, I know trusts are currently involved in a number of innovative and modernisation projects, which it's hoped will deliver greater capacity for new patient appointments and swifter responses to referrals. It's of note these projects are in the absence of additional funding. In respect of adult mental health services more generally, initiatives introduced across the region include the South Eastern Trust recently implementing a mental health liaison service at the Ulster Hospital that provides rapid assessment and early intervention to people who present at the hospital with mental health problems, and the Southern Trust, where referrals deemed to be of mild to moderate complexity are triaged through to the Steps to Wellness service established in October of 2022.
Keith Buchanan.
Thank you, Minister, and thank you for answers so far. Minister, the statement you delivered this morning on a reconfiguration framework for better outcomes, will this have any impact on the current waiting times? Do you see any advantage in that to reduce waiting times?
Well, I would hope that would be a product of the reconfiguration of hospitals, because what I'm talking about is a network for better outcomes, and part of that network will be recognising that while not every hospital will deliver every service, some hospitals will become centres of excellence for certain specialties. So that should apply to mental health and well-being as much as it applies to physical health.
Honourable Flynn.
I know that the Minister is due to speak at an event on Thursday morning around the mental health and well-being of our babies and infant mental health, and I wanted to ask if he could give any consideration to invest in child and adolescent psychotherapy services, because at the minute we don't have any fully commissioned service for child and adolescent psychotherapy. Minister.
Well, I thank the member for the comment and the question, and gently I have to say that the irony klaxon is going to have to sound on that one, because the nature of the budget for this year for the Department of Health means that what we are trying to do is consolidate and preserve existing services. There are many additional services that are brought to me pretty much on a daily basis that I know would help deliver better outcomes, would take us into areas where we are not but where we should be. That sounds like one of them. I can afraid on current budget I can make no promises, but I'm very happy to listen to the member offline about the advantages and the benefits of that service.
Danny Donnelly.
Following debates yesterday, we know that mental health service provision across Northern Ireland is very inconsistent. Will the Minister commit to ensuring consistency across all trusts, or enable patients to access trusts no matter where they live?
Sure.
I thank the member, and I think the comment strikes a chord with what I'm trying to achieve in terms of delivering better outcomes. So I've said previously, there was a temptation perhaps to look at the 5 geographic trusts and say, should we not have one single trust for the whole of Northern Ireland? But I think that would be almost like the equivalent of a cosmic black hole absorbing all the kind of resource and focus of staff, not just in the department but in the trust. So, as I've said, within my own mind, as I've said to the trust, you are one trust, And I suppose the outworking of that and the definition of success in terms of that is to have regional services where we look at which trust is delivering best practice and then turn that into common practice across the other 4 trusts.
Call Cheryl Brownlee. Minister.
Thank you. I thank Ms Brownlee for the question. My department's ambitions for the development of our workforce are outlined in the Health and Social Care Workforce Strategy 2026. That was published in May of 2018 and it covers the period 2018 to 2026. It's an ambitious programme of work. It reflects the multifaceted approach required to develop our workforce with the aim of ensuring the right numbers of staff with the right skills are in place to deliver effective treatment and care. Since publication of the strategy, the Department and HSE employers have invested significant time and resource in stabilising and in growing our workforce. This has involved delivery of a comprehensive programme of strategic workforce planning, increasing the number of commissioned training places across healthcare professions, introducing more effective processes for recruitment, complementing our locally trained workforce with our highly valued international recruits, and developing initiatives to support staff retention. This strategic approach to workforce development has supported a 16% increase in whole-time equivalent staff employed directly by the HSE since 2018. And while this increase is welcome, my department's strategic workforce planning has identified a requirement to further expand the number of training places we commission in order to secure the continued local supply of staff we know are needed to meet fully our workforce needs going forward. Unfortunately, my department is currently not in a position to do this, and that's because current levels of funding are wholly inadequate. And the one-year departmental funding cycle seriously constrains assessment of affordability and frustrates the long-term investment in education and training which we need to deliver the right numbers and skills of staff required to meet current and future demands for our services.
Cheryl Brownlee for supplementary.
Thank you, Mr Deputy Speaker, and thank you to the Minister for his answer so far. As you know, the number of children with SEN has risen sharply in recent years, which has obviously exceeded the capacity of the health and social care workforce. So could I ask you, Minister, from your department, what action will you take to ensure that you're taking into account all the relevant data from the various departments to ensure every child with special educational needs is receiving the care that they need from the person, the most appropriate person at the most appropriate time? Thank you.
I thank the member for her supplementary question, and I think it's very important that we recognise that this is a cross-departmental issue, which is not to shirk the role that the Department of Health and the various trusts and arm's-length bodies have to play in this. I know from personal experience of a young man who has special educational needs, and I have to say I don't think his needs and the needs of his family have been particularly well met across a number of government departments. So I would just like to assure the member that in terms of special educational needs for our young people, I very much do wish to see improvement and will play my part as Minister of Health.
Ms Cummins.
For his answers so far. Minister, you will be aware of a very serious situation that occurred on the weekend of the 21st of September, where Daisy Hill Maternity Unit was forced to divert all admissions to Craigavon until the Monday morning. And that was cited as staff shortages by the Southern Trust. Can the Minister therefore outline what urgent steps his department will be taken to ensure that the workforce for maternity services, both Daisy Hill Hospital and Craigavon, are both stabilised and secured to ensure that this situation doesn't arise again in the long-term future?
Minister.
Well, I thank the member for the question. I am aware of what happened, and you did have staff being transferred from Daisy Hill to Craigavon area and from Craigavon area to Daisy Hill, and this was because of workforce pressures due in the large part, as I understand it, to absences through ill health and other reasons. And these things, of course, do happen, and to try and have a workforce robust enough to withstand every emergency is probably a challenge beyond the capacity of the health and social care system in Northern Ireland, given the current constraints on resources, workforce and budgets. So I would struggle to give an absolute assurance that this would never, ever, ever happen again. But I will give an assurance that it is my expectation that trusts will try and manage these unforeseen issues as they arise to the best benefit of patients and of service users.
Mr. McNulty.
Minister, we are hearing more and more about reports of healthcare staff moving south due to the benefits of Sláinte care, and why wouldn't they? What steps is your department undertaking to better retain our staff so we do not have repeats of what happened last weekend in relation to a divert from Daisy Hill Maternity Unit to Craigavon? And Minister, your previous answer doesn't really stack up when there was a bank of midwives actually asked to retire and return. So there are adequate numbers, there are enough midwives to sustain services.
I think you've asked your question.
There are enough midwives to sustain services. How on earth can it be justifiable to close Daisy Hill's maternity suite for emergencies on a particular
Question,
weekend?
please.
Well, I'll choose to answer, I think, two of the multiple questions the member put towards me. In terms of trying to retain staff who are being attracted by Sláinte care, the fact is we can't compete, not on salary. We simply cannot compete on salary. So we have to compete on terms and conditions. We have to try and make sure that this is such an attractive health and social care system to work in, that the money does not become the deciding factor in terms of where staff decide to ply their wares. And part of that is about improving the outcomes, because I've always said better outcomes are not just for patients and service users. I'm talking about better outcomes for the tens of thousands who deliver health care in Northern Ireland. And, you know, creating, for example, a network of hospitals where some are centres of excellence and specialism may help to retain staff, because increasingly it seems to me that doctors and nurses want to specialise in particular areas, so we'll give them those opportunities in centres of excellence. That may help in terms of retaining staff. Just in terms of staff shortages and the workforce, I would say this to the member, because he brings up nursing and midwifery. In terms of vacancies in the HSC, at the 30th of June this year, in terms of registered nursing and midwifery places, there were 1,211 vacancies, 5.8% of that workforce. And in terms of nurse and midwifery support, while there were 464 vacancies less than the previous figure, that represents 8.4% of that particular workforce. So the issues actually do exist.
McAllister.
The Minister for his answer so far. I want to go back to the original question and just ask regarding the safe staffing legislation in terms of the difference that legislation will actually make without the staff that is required to fulfil it.
Well, I think the legislation gives us the framework, it gives us a set of principles, it gives us the matrix at which to judge how well we are doing. But of course, if the physical, actual numbers do not exist, all that does is say that we have a problem. The question is, what is the solution? And it goes back, I think, to making working in our health and social care system as attractive as possible. And of course, to an extent, that is about salary. But that is not the be-all and end-all, it seems to me, in terms of a profession which many people look on not just as a career, but as a vocation.
I call Stephen Dunn.
Speaker, question 3.
I thank Mr Dunn. As was made clear in the elective care framework published in June of 2021, and again in the update from June of this year, the demand for first consultant-led outpatient appointments in the South Eastern Trust continues to exceed capacity. So regrettably, patients are experiencing excessive waits for appointments and treatment, which is not the service the Trust would wish to be providing. The member will be aware that both I and my predecessor submitted an ambitious ask to the Executive earlier this year to reduce our waiting lists, and there was a particular focus on those outpatients waiting the longest length of time. Unfortunately, the budget that was agreed by the Executive and by a majority of MLAs in this chamber provided zero targeted funding, and as a result of the continuing budget position, we are losing opportunities to see and treat more people each and every day. Nevertheless, the Trust is continuing to seek alternative ways to provide outpatient consultations to help reduce waiting times through initiatives such as virtual or telephone appointments that provide advice and guidance. The Trust is also seeking to implement a patient-initiated follow-up and enhanced triage clinics to further reform the outpatient service. Last year, over 22,000 patients did not attend their allocated appointment. Without timely prior notice, these appointments cannot be offered to other patients on waiting lists, and each of these missed appointments not only wastes a consultation slot, but it can cost between £250 and £2,500. And to address this matter, the Trust has already implemented text reminders for all its consultant-led clinics.
Stephen Dunn for supplementary.
Thank you, Mr Deputy Speaker. Thank the Minister for his answer, and I very much appreciate the challenges within outpatient waiting lists, but it also goes beyond outpatient appointments as well. Last week, one of my constituents attended the Ulster Hospital's emergency department at 11 p.m. on Wednesday evening. It was some 9 hours later at 8 a.m. before they were seen by a doctor. Would the Minister agree that something is not right in a brand new emergency department, given these waiting times, particularly alongside the demands on our GPs, pharmacies, and also in light of the Trust decision to close the Ards and Bangor MIUs in recent years?
Sir.
Well, I thank the member for his follow-up. I have to say, in terms of moving the minor injuries from Newton Ards to the Ulster Hospital, that is something I supported on the basis of the clinical evidence that the Trust presented when I went to a meeting as a constituency MLA. And part of the reasoning was that you're putting the MIU, the minor injuries, right beside the emergency department, also the MRI scanners, the X-ray machines, and all the facilities of an acute hospital. So it seemed to me that on clinical need, that was the right decision. And let us remember, we're talking moving a distance of 4.6 miles along a dual carriageway. In terms of pressures on the emergency department, I would say to the member, I'm well aware, a family member of mine was admitted to the ED at the Ulster Hospital on a Monday evening, which is the worst in terms of the pressures, and it was remarkable to watch the nursing and the clinical staff delivering unrelenting professionalism in the face of endless pressure. I think what the Trust are now trying to do in terms of relieving pressure on the ED is not only to have that minor injuries unit, but then to have a third unit alongside the minor injuries and the emergency department, and that's a kind of critical care unit, so that I think the plan in the long term would be that GPs would be able to refer patients directly into the urgent care unit, the critical care unit, bypassing the emergency department, and thus relieving a lot of the pressure on the ED. And I've seen that in hospitals elsewhere across Northern Ireland, and it seems to be working well, and I would say that is part of the future of reform of health service delivery.
Alan Chambers.
Minister, one of the specialities that unfortunately are experiencing lengthy outpatient appointments are dermatology assessments. What particular efforts have you as a Minister taken to help these patients, especially those who have been waiting the longest lengths of time?
Well, I thank the member. I think the disappointment and the frustration with regard to dermatology outpatients is the same for many patients who are on long waiting lists, and that is the failure to secure the bid that we made for £135 million to be ring-fenced to tackle waiting lists. So, for example, in terms of new outpatient assessments for dermatology patients, we could have seen 6,000 patients, 6,000 who have been waiting over 4 years for an appointment, and the cost of that would have been £2.8 million. And the member may be interested that in other categories, for example, cataract, we could have seen 2,800 patients for £5 million. In terms of mega clinics, and we have the evidence, not just locally but internationally, mega clinics work, we bid for £10 million, and had we got that, we could have seen 20,000 patients across a whole range of specialities. And I know many members are interested in cross-border work and the reimbursement scheme, and many have asked if it's ever coming back, and the answer is currently no. But had we got our 135 million for waiting lists, we would have spent 31 million on that reimbursement scheme, and that would have meant 4,000 patients who've been waiting over 1 year, largely for orthopaedics, would have been seen.
Egan.
Minister, I'm glad to hear you recognise the clinical evidence that was presented to all elected representatives when it came to the Bangor and Ards minor injuries units. Is that something that's supported by your party colleagues?
Sorry, did you say you supported the move?
Yes.
Right. Sorry, I acknowledge that. I felt there was... let me correct myself then. I think the majority of elected representatives were against the move. I do apologise if I have misrepresented you.
I call on you, Murphy.
Please.
Minister.
Earlier this year, my department increased funding to community pharmacy, bringing the opening position for community pharmacy to £147 million this year. That's an increase of 19 million from financial year 23-24. And it's also the highest level of funding to date in Northern Ireland. And I would also say it compares favourably to the rest of the United Kingdom, representing a 40% increase in funding over the last 6 years. My department has repeatedly acknowledged the concerns raised by Community Pharmacy NI and by individual contractors themselves in respect of drug pricing increases and differences due to inflationary and cost of living increases generally. There are significant difficulties in terms of financial planning across the HSC, and my officials are continuing to work closely to review the position as we move forward. However, whilst we have the aim of keeping that under review, containing costs as much as possible is a priority, and you'll appreciate significant changes may give rise to further pressures having to be managed in the year. My department recognises the valuable role community pharmacy has within health and social care, and I'm happy to report that a strategic plan for community pharmacy 2030 was launched in May of this year. The strategic plan for community pharmacy aims to fully realise the potential of community pharmacy services to support better health outcomes from medicines and in preventing illness. Implementation of the strategy will not only support the elderly and vulnerable, but the whole population. And my department will continue to work with CPNI and the pharmacy profession in order to progress a phased approach to implementation of that strategic plan over the coming years, subject, of course, to appropriate funding.
Murphy for supplementary.
As Councillor Collier, I'd like to thank the Minister for his answer. I've spoken to a lot of community pharmacies over recent months in my own local community, and one thing that they constantly raise is drug tariffs. Has there been any progress made on developing a tailored drug tariff for the North, given the difficulties that many pharmacies are experiencing?
Minister.
I thank the member. Now, Northern Ireland does have its own drug tariff. Following the 2010 judicial review and subsequent consultation on improving arrangements, the then Health Minister decided that the English drug tariff should be used as the basis for reimbursement of medicines supplied, with modifications for local Northern Ireland circumstances, such as the services we provide here. Now, this policy position was reaffirmed by Minister Swan in May of 2024, and I have to say at this stage I have not received a robust argument for moving on that position.
McLoone.
Just following on from that, I would support that observation about drug tariffs and the pressures that's on pharmacies, particularly in rural areas. But can I ask the Minister, is he considering expansion of the Pharmacy First service across the pharmacy network to help address access difficulties that many people are experiencing in the primary care sector this winter?
Sure.
I thank the member for his question. I am certainly open to looking at that. I think my entire ambition as Health Minister is what is being called the shift left. In other words, getting away from hospital care and as close to community and primary care as possible, and that is not just about GP services. I think pharmacies have a critical role to play. I know that I would tend to go to a pharmacy first, if at all possible, certainly to the GP next and the last resort. is to go to the hospital. And I've said on many occasions when I've been out and about as Health Minister, in an ideal world I would want everybody to get their health care at home, if not at home, as close to home as possible. The second worst outcome is to have to go to an acute hospital, and the worst outcome is to have to go to an acute hospital and stay overnight. So pharmacy first is certainly very much on the left side of the field where I want to be playing healthcare.
Yes, and
may I thank the Minister for remarks so far. Minister, there's been some public references in the media in recent weeks about a number of community pharmacies closing. Does the Minister have confidence that there still remains very good access to community pharmacies across Northern Ireland?
I thank the member for the question, and I do believe, and the evidence supports this, that Northern Ireland is well provided for in respect of access to community pharmacy services. The facts are there were 511 community pharmacies in Northern Ireland as of the 31st of March this year. That was a reduction of 14, or 2.7%, compared with the 12 months previously. But I should also note 2 further pharmacies have closed since then. So we're now at 509 on the pharmaceutical list. That's 1st of September of this year. Now, we don't always know the reason for closures, as contractors don't have to give the SPPG a reason for closing, but we are aware that some of the branch closures of Boots UK were a result of a consolidation exercise by Boots here in Northern Ireland. And the number of community pharmacies per head of population in Northern Ireland is 30% higher than in England, 16% higher than Scotland, and the same in Wales. So yes, there remains good access to community pharmacies across Northern Ireland. 99% of the population live within 5 miles of a community pharmacy. And adjusting for the higher rate of prescribing in Northern Ireland, it still results in a higher rate of provision compared with the rest of the UK, 6% more pharmacies per item dispensed than in England.
Call Philip Brett. Minister.
The GP out-of-hours service is a core element of health and social care provision in primary care. The service is available Monday to Friday from 6 p.m. to 8 o'clock the next morning, as well as 24 hours at weekends and during public holidays. The majority of patients who contact out-of-hours services across the region do not require to be seen face-to-face. The percentage of patients who contact the out-of-hours service and who need to be seen in an out-of-hours centre, known as base visits, has changed quite dramatically over the years. In 25-16, for example, base visits accounted for 40% of Dalriada's urgent care patient contacts. In 2019-20, base visits had reduced to 30% of contacts. In 2023-24, 76% of Dalriada's patient contacts were managed by telephone or by video call with a clinician, home visits accounting for 5% of their contacts, and patients seen face-to-face accounted for 19% of contacts. Due to workforce challenges, Dalriada do not currently have the capacity to provide a service across 4 centres, with the service being delivered from their main hub in Ballymena and the new out-of-hours centre at Antrim Area Hospital. This, though, is constantly under review. These workforce challenges are common to all GP out-of-hours services across the region. Consolidating services to a smaller number of larger centres has improved the recruitment and retention of staff due to the benefits associated with collaboration, peer support and equitable workload distribution. All GP out-of-hours providers are expected to review activity levels and capacity challenges in order to ensure the efficient use of resources and provision of an effective service within the budget allocated.
Okay, as we started a minute or two late, I'm going to allow a quick supplementary question, Mr. Brett, and a quick reply, please, Minister.
Thank you, Mr. Deputy Speaker. And I'm not quite sure, Minister, that you answered the listed question as to when White Abbey Dalriada Care would reopen, but I just want to put on the record that serves some of the most deprived communities in Northern Ireland who have no access to public transport to either Antrim Area Hospital or to Ballymena. So will the Minister commit in his reconfiguration plans that it's an executive-wide strategy and that public transport and ensuring that those who are least well off in society also have access to much-needed community support?
Minister.
I draw a distinction between access to service and face-to-face access.
Members, that ends the period for listed questions. We will now move on to 15 minutes of topical questions, and I call Colin McGrath.
Minister, as a Minister responsible for child safeguarding, can I ask the Health Minister what safeguarding obligations rest on organisations, including political parties, when concerns about child sexual exploitation are raised with them, and do they have a duty to disclose this to external organisations?
Well, I thank the member for his question, which I take it he intends to be rather topical indeed. I think to a certain extent part of this is about legislation, and I'm trying to get myself to the correct part of the law, but also about common sense, about what is the right thing to do. But Section 5 of the Criminal Law Act Northern Ireland of 1967 outlines penalties for concealing offences. These provisions could be applied in the case of an individual who has knowledge of an offence and fails to report it. Of course, health and social care trusts have a duty to safeguard and promote the welfare of children, and although there is currently no mandatory duty to ensure employees in the public, private or voluntary sectors report safeguarding concerns, I think all employees should comply with their employer's safeguarding policies, and they should have policies, of course, including reporting processes in relation to safeguarding and protection concerns. So there is a legal duty, but there's also a moral duty on everybody to ensure children and vulnerable adults are safeguarded and to report any concerns to the relevant authorities. Now, my department intends to introduce the Adult Protection Bill during this current mandate. Drafting is largely complete, and the business case is currently being considered in the department. The draft bill will place a statutory duty on the Health and Social Care Trusts, on the PSNI, on Public Health Agency and the RQIA and independent providers to provide health and social care services to report to the relevant trust any cases where they believe there is a reasonable cause to suspect a person is an adult at risk and in need of protection.
Time's up. Mr McGrath.
Thank you very much, Mr Deputy Speaker, and I hope that that same protection can be provided for children if we're going to provide it for adults. But can I ask the Minister, as a Minister responsible, are you concerned by reports today that the British Heart Foundation was not informed by a political party that a member of staff was being investigated by the police for child exploitation?
I am aware of that report, and I am concerned by it. And frankly, I would say to the member, it takes me back, I'm sure, over 20 years to my time at Ulster Television. We produced a documentary for the Counterpoint series one night about a man who had spent time in prison for child sex abuse offences. And we discovered that he had got a job with a charity. The charity owned an activity centre in the Mourns, which was a residential centre. And children were going and staying weekends under his supervision. And the point was the charity didn't know about the man's record. And it became very messy. And here we are over 20 years later. And I do think common sense needs to prevail. And people need to recognise that there are occasions when these things need to be reported and put up front. And I'm not even sure the extent to which the Safeguarding Board, which kind of comes under my department, has a critical role to play in this, because they're more about giving a voice to children rather than ensuring that adults are reporting on people they know who perhaps should not be going into roles, certainly not without those employing them understanding the full nature of their background. And it takes me to the idea that we're calling for a duty of candour in health and social care. And as I've said before, you've got to strike a balance between avoiding the chill factor, which puts people off coming forward to say certain things have happened, and ensuring you've got an atmosphere where people feel that they can come forward and say, you need to know about this. But yes, I am very disturbed by this news.
Colin Matheson.
Thank you, Mr Deputy Speaker. Can the Minister outline what role his department or the trusts play in terms of funding or providing nurses for special schools in Northern Ireland?
So did the member say nurses or nurseries? Nurses. I am not aware of that detail, and I would be more than happy to write to the member, and maybe in his supplementary you want to define exactly the areas that he would like me to address.
Matheson, supplementary.
Thank you, Minister, and yes, I'm happy to provide more detail. I met today with a group of special school principals from the South Eastern Trust area, along with the Education Minister and officials from the Education Department, and they informed us about very difficult situation they are facing, where nursing provision is being withdrawn from their schools, and indeed other schools across Northern Ireland where there is no nursing provision in special schools. Would the Minister commit to meeting with those principals to hear their concerns and the impact that is having on their schools, dealing with some of the most complex medical needs of children in the education system, and to work with the Education Minister to address this issue?
Minister.
I thank the member. I very much do commit to such a meeting. I think, as in many of the issues that we face as a devolved executive and assembly, the answers do not lie with a single department, and in this case, cooperation between health and education would be critical. And I have enjoyed working with officials from the Department of Education, as I've enjoyed working with officials and the Minister for Justice. A lot of these things are cross-departmental, and I think if we are going to be a mature, devolved set of institutions that really delivers for people, then that's the sort of road we have to go down. I apologise, I have no detail on this, but I look forward to learning.
Colin Crawford.
Deputy Speaker, will the Minister join in welcoming me with the recent appointment of new contractors to the Ballymoney Health Centre and Portstewart Family Practice?
Well, I thank Mr Crawford, and I very much welcome the appointments, which in the case of Ballymoney Health Centre takes effect this very day. The positive outcome for both practices followed extensive work to identify new GP contractors to take over both, and that followed the handback of the contracts by the previous contractors. So I would like to take this opportunity to wish the new contract holders the very best with their new responsibilities. I look forward to working with them in the time ahead. In fact, I would also very much welcome the opportunity to visit. On my mother's side, I have family from Ballymoney and from Portstewart, so it wouldn't be a chore, it would be a pleasure.
Thank you, Minister, for your answers, and I also agree that it's good news today. Could the Minister provide an update on the GP fellowship scheme, please?
Minister.
Yes, this is an important scheme. The fellowship scheme is designed to support recently qualified GPs in the crucial early stages of their career. Fellowships offer young GPs an opportunity to transition from a training environment to an independent practice by providing them a supportive workplace with opportunities for personal and professional development. And actually, I commend that to my good friend Mr McNulty, because he asked about how we retain staff in the face of pressure from Solentary Care, and I said it wasn't just about salaries, it was about working environments, and this fellowship scheme is very much a part of that initiative. The scheme runs for 12 months. During that time, fellows have access to a broad range of experience in primary care, covering three main areas: clinical work in a supported environment, experience in a specialist field of their choice, and taught and practical learning in areas such as leadership, confident communication and quality improvement. My department very much values the fellowship scheme and the chance it provides for recently qualified GPs to have access to an attractive portfolio of opportunities. Looking to the future, my department is considering the potential for how the scheme might be further developed, subject of course to available funding, such as to extend the range and scope of fellowship placement opportunities, and provide for educational bursaries to be available for all fellows. GP federations have recently launched a fellowship scheme in the Southern Trust designed to attract salary GPs to work in practices which they have taken over due to contract handbacks. The first round of recruitment has completed, with 3 offers made to candidates. the GP Federation Contract Management CIC have now launched a second round of recruitment, which is ongoing. A good news story, I would suggest, Deputy Speaker.
Stuart Dixon.
Minister, October is Breast Cancer Awareness Month, and with 1 in 8 women expected to face breast cancer in their lifetimes, early detection is critical. Can you outline to us the options available for women with high-risk breast cancer to effectively manage and monitor the cancer risk?
Well, I thank the member and I acknowledge his interest in this broad area. As I think I have said before, it is my intention to introduce a regional service in terms of breast cancer. The objective is to allow each and every individual to go online and book a screening, either the first available one, wherever that is across Northern Ireland, or if they prefer to go local, to book themselves in and wait perhaps a little bit longer. Waiting times are just not acceptable, and I think the member has experience of cancer, and I bow to his knowledge and his interest in this area. But I have made clear that in my time as Minister, one of the areas that I want to tackle, one of the most difficult areas, is cancer, along with waiting lists and mental health. And I would certainly welcome any observations he has in his supplementary comments in terms of improving the service.
Stuart Dixon.
Thank you, Minister, for your answer. My question isn't so much around the waiting list, but it is rather around the expansion of breast cancer screening programmes, specifically to enable earlier, more frequent access for those who are at higher risk, especially those with genetic predispositions or other elevated risk factors.
Minister. Well, the member will be aware that the waiting lists are they're just terrible. It's easy to say they're the worst in the UK, but we've got to remember that the statistics reflect people who are in pain, people who are suffering, who need help. And the fact, I have to say to the member, the fact is that given the budgetary constraints, what we're doing is trying to consolidate. So when it comes to cancer, what we're doing is we're trying to prioritise red flag and life-threatening conditions. And really, in terms of the current budget and the ability to reform health service delivery at pace, I'm afraid I can't promise this House that we can do a lot better over the course of the rest of this financial year, except to assure the member that when I meet officials and when I talk to clinicians, we all recognise we have to try harder, we have to do better. But I can't promise the member any sort of promised land in the near future.
Call Alan Robinson.
Speaker, Minister, given your recent intervention where you said that you weren't in favour of mandatory vaccinations, did you give any thought to withdrawing the consultation and starting afresh?
Minister.
I thank the member. No, I didn't give any consideration to withdrawing the consultation. Let me be clear. What we have at the moment is the protections of an Act from 1967, which is all well and good if it's a named infectious disease. But beyond that, we don't have any protection. So, if it's biological, if it's chemical, it's radiological, if we are in that unfortunate position, much like COVID-19, we're going to have to make it up as we go along. So, the objective of the bill is to offer the opportunity to bring in legislation that would give us protection on an all-hazard basis. And it seemed to me, if you're doing that, then the logic is to put all options on the table. And it's not for me as Health Minister to decide that I'm going to take certain options off the table before we even allow the public to have their say. So that is the basis on which some of those proposals are in the consultation. I think it's quite right that the public should be encouraged to respond and make their views known. And after that, then a bill will be drafted and it will be brought to the House, and it will go through the proper and full consultation and discussion and debate and amendment and approval basis.
Time is up. Members, we now return to the... Mr. Brett.